All right, we are resuming. Tim is here. He's out of his meeting. We're doing cardiac arrest. I'll hand it over to him.
Thank you. Let's see if I can able to use your stuff. Okay, they call this stuff refresher for a reason. Is because all of you know as much as I do about this, and it doesn't hurt to go over things again and again, I suppose. But this title of this is a little bit misleading. Yeah, it's adult cardiac arrest, but I will have some rhythms that the patient actually is not in a cardiac arrest situation at that particular moment. We will talk about what type of rhythm it is, the treatment, maybe some of the reasons of why they would be in this particular situation or this particular rhythm or dysrhythmia. And this is I hate your computer. Okay. You can't read this, but if you take an ACLS in the last 3 or 4 years, this is adult cardiac arrest flow that you have in your ACLS books or it's printed off for you. I'm not going to read this to you. You've seen this numerous times. If you just so desire to have a copy, I'll make a copy for you. There again, there's probably no reason for that. You know how to treat your patient. At least I hope so. Okay. All right. You can read as well as I, but you have a 44-year-old male that's unresponsive, has no respiration, no pulses, fine, laying on the floor, and no bystander CPR. And you look at this rhythm, if you just saw this on a oscilloscope or a strip, you would say, well, that's a sinus bradycardia. Well, it is a sinus bradycardia per se, by just looking at it. But since the patient has no pulse, very obviously this patient is in what? Pulsus electrical activity, or PEA. So, from that point, since we've identified that dysrhythmia, what is the first treatment for this rhythm? And you're right, but let's don't forget the basic treatments. Is if you saw initially it said there's no bystander CPR present, so you're going to start CPR and have them on O2 via BVM. I wouldn't intubate at this particular point yet because there's something that's much more important. As long as you're able to ventilate the patient adequately with just a BVM with an OPA or NPA in place. But the CPR is the first treatment that this patient requires. Now, the next thing you would do, or we should do, is start an IV or IO. Now, what would you do in the clinical environment or in your EMS environment that you had this patient in reality?
Well, that was quick. Who's there today?
Awesome. Good job, guys. Ladies, excuse me. Well, it doesn't really matter personally if you do an IV or IO. Used to, in some protocols, actually still take this, that you do 2 sticks before you do an IO. Well, that's probably in patients that are still perfusion. This patient is in cardiac arrest. So you're not wrong to start off with doing an IO first. An IV is the preferred method, obviously, of establishing a route for medication. So what meds would you give? And Mike said, you give what? No. Think about this. The very first drug you give in any cardiac arrest situation is epinephrine. Now, how much would you give? Well, I'll give 1. Okay. You can give 0.5 to 1. How often do you give it, assuming they stay in a cardiac arrest situation? 3 to 5 minutes. How much do you max out on? 3. Who knows?
You just keep going till you're out of
You keep going till the cows come home. That's what was taught 100 years ago. I didn't know what that really meant, other than it meant kept giving them medication. Okay, would you pace this patient or not? Is there any point in pacing this patient?
What was it? Bradycardia.
It's bradycardia, but it's PEA.
Oh, no.
No. So we want to know, I'm going to stop right. We want to know why this patient is in PEA. So what would we do? We would think about our HCP. Some of the H's are hypovolemia, hypoxia, acidosis actually is one, hydrogen, which is acidosis. And there's other H's, and your T's could be your tamponade, it could be toxins, there could be a lot of reasons or trauma why this patient is in a PEA rhythm. What if you determine that they had cardiac tamponade? It'd be very difficult to determine that. They may have the distended neck veins. That might be an indication that this is a tamponade. Is there anything that you can do in pre-hospital setting for cardiac tamponade?
More gas.
Pardon me?
More gas.
Use a lot of gas, best fluid ever in the pre-hospital setting. They don't teach this anymore, but used to you do pericardial centesis and use a spinal tap needle with a 40, 60 cc syringe. I've actually done it before. It's not on a patient that was per se, well, they were dead if they're in this rhythm. It was in ED a couple times to get a blood alcohol. So that doctor asked, I just sure like to. But we can't really do a lot for a cardiac tamponade except, like Shannon said, a lot of fuel. Take the hospital. When all else fails, take the hospital. What if it's a tension pneumothorax? Would you be able to tell if it's a tension pneumothorax? Say you intubated them, okay? You got good breath sounds on the right, okay? Abs on the left. Now, think critically here.
Pull back your tube.
You're gonna pull back your tube a little bit because you might be right main. Okay, you pull it back a little bit and you ventilate, and there's no breath sounds on the left. And you know you're at the proper depth. So what might this possibly be at this point? Attention pneumothorax. So what can you do for that particular? Yes, a couple of places to do it. The second or third intercostal space, mid-clavicular, or the fifth, mid-axillary. And they're actually they experts, people a lot smarter than I, almost everyone. Says the best place to do it is mid-axillary, the fifth intercostal space. You can do it wherever you want to. Have you ever, I've done it a few times, and not bragging, it's just reality. After over about 40 years, I probably should have done it a few. It's not difficult. It's really not. I used a 10 cc syringe. You can use a larger one if you want. And use what kind of needle you get. Like we carry in the truck. You could use 14. It'd be long enough. And since we didn't carry stopcocks, and I don't think we still do, which we really need to, is you use the finger of a glove. And that would be your flutter valve, so to speak. And you find your place, and you go just superior to the rib. You don't want to go inferior to the rib above it because that's where your nerves and vessels lie. And you introduce the needle in, and if it's a tension, it's going to push the syringe back. When it does that, take it off, and when they breathe out, or you breathe for them, okay, and they exhale, so to speak, it's going to come out the valve. So it's not a difficult procedure. Just make sure that you know this, you might have to do it multiple times. And actually, we have a kit actually on board that a kit for that, I believe, if I'm not mistaken. All right, intubation, keying airway. We don't use keying airways anymore. I thought I'd change this slide, but obviously I did not. We actually use eye gels now. Can an EMT in Arkansas drop an eye gel?
No.
Found that out yesterday. I didn't think you could, but in Missouri apparently they can.
Missouri, Oklahoma, Mississippi.
Arizona used to be able to also. There's some states that do EMTs innovate. And the thing is, innovation, I teach you in innovate in 5 minutes. Probably CE skill. Might not be able to teach you in 5 minutes when you need to, but the psychomotor skill is simple. Okay, so you're going to intubate this patient. What is the prognosis of someone that's in a PEA?
DRT.
Yeah, it'll probably be DRT. Unless it's hypovolemia, tension pneumothorax, and you get to them quickly. Or if it's acidosis, you're not going to know that. Well, if anybody's down for a period of time, it's acidotic. So giving them bicarb, is that gonna hurt them? No. Could it potentially help them? Potentially, yes. Any question?
I don't remember, right, on PEA is not the purple line, right?
No, that's, so
That's a
an
big-
emboli, they've had a left ventricle complete infarct or something. Do you see that? We've all probably seen it.
I've seen it once.
Okay. And it is, basically, it is, they pretty much a straight line, the purple.
Me and Father seen it one day, the guy was still holding the chainsaw. running.
He wasn't running.
He wasn't running, but he was sitting there on the ground.
Sorry, that wasn't. Have any questions? PEA. Here's the thing. I mean, we got to refer back to our basic skills. If you're a medic, you're taking ALS. Most of our careers, the runs that we've done are transports to the BLS runs. They mostly have. But don't forget your BLS stuff. And that was like, what would we do first? Well, CPR.
That was the story that I told yesterday in class about Saturday was a 3 medic truck and nobody knew what they were doing because, it's like who takes charge, who's on first, who's on second,
And I agree with that.
Yeah.
And I don't mind working with the medic because I like to drive. But most of my career, I preferred to work with the basic. I got a quick story to tell you. There was 3 medics on this scene. This patient was in cardiac arrest. Stacy Rightly, I don't remember the other one, it's irrelevant. But a guy named Brent Gleghorn pulled up on the scene. We were all in the back of the truck, and man, we were starting IVs, we're intubating, we're pushing meds, we're saving him. Brent kind of tapped me. You reckon you might want to do a little bit of CPR? Because you get tunnel vision.
Yeah.
It's like, oh yes, that would be a good idea.
That's basically the same thing. Me and Judge Moore, right over here behind town and country, little baby up. Of course, we were basic.
Mhm.
David was coming from Viola area.
Yeah.
David got there and he's like, guys, let's go ahead and push with us. David, she's got a pulse. She just ain't breathing. Oh, okay, my turn.
Yeah, my turn now. I brought the toys, so I get to play with them. So anyway, it's most of your calls are BLS calls. Even in Metro, I worked at MIMS for a while, and you're never 5 foot at a time. You're never probably more than 5 to 8 minutes away from the hospital. So it's swoop and scoop. Basically what you did you stuff in round. Other than a cardiac arrest, you can stay and play on that. Yes. But what I'm getting at is it doesn't matter the volume that of your service, still about the same percentage of runs are BLS runs, and at least 85%, if not greater. I don't remember what they said. Doug suggested. I think he thought more than that was. I may be wrong, but at least 80 to 85% are BLS runs. And that's not to say you don't do your ALS skills on those patients because you're following your protocols. And the hospital likes the patient to have an IV when you arrive. They don't always have an IV when I arrive with them, but they'll have a couple of holes in them that they didn't have previously. Okay. Somebody read that for me. Try to read. Okay, everybody can read it themselves, even you in video land that's too lazy to show up and listen to me. I'm kidding. It's a joke. Okay, they're 89 years old. They're in a nursing home. That doesn't mean they didn't have a quality of life, but probably not a great quality of life if they're in a nursing home. So this is how you found this patient. And no respiration, no pulse. Nursing home can't find a DNR. But this is the rhythm. And you check it in how many leads minimum.
3.
Check them at least 2. There's nothing wrong with 3. But they do say for sure 2 leads. Check them at 3, it's not gonna hurt.
Yeah.
Confirming the confirmation.
So can I interrupt right quick?
Yes.
Okay, so we were discussing during post-ROS about IV access versus IO access. So the study, I've seen this yesterday at Jim's, says a recent study published in the NEJM compared IO versus IV for out-of-hospital cardiac arrest. The IV-IO trial conducted in Denmark aimed to determine which method results in a higher return of spontaneous circulation. Ross rates, which they're very close. It's very narrow. But 30% for IO versus 29% IV. 30 days survival, this one's probably the highest. 12% for IO and 10% for IV. And favorable neurologic outcome at 30 days is 9% for IO versus 8% IV.
That's interesting. I'd like to see more trials done on that. They're not, here's the thing, that's great. In Denmark, I'm sure, high standards of medical care and scientific, so it's legit.
Yeah.
But it'd be interesting to see it done maybe in, let's say, Houston, Texas, or
Yeah.
King County, Seattle, Washington.
When I was discussing, we were talking about IVIO access earlier, and I said, I'm lazy. If I know there's not a definite viable possibility, because I don't do IO as much, usually that's my first line just for the practice.
And that kind of proves the point, what you're saying by reading, well, what you're reading to us,
Yeah.
there's a little bit higher discharge from the hospital
Yeah.
with using IO.
Yeah.
That's interesting. I would have thought it'd been just the opposite.
Okay. Resume.
No, that's good. What are you gonna do here? Let's go to the next one. We know that is, we've checked in, Shayna being a good medic, checked in 3 leads. Me being a little lazy, I only checked in 2. I'm not passionate, it's a good thing.
That thirdly, you never know.
We never know. They have a little bit of
Fine B-fib.
funny little beats and think, hey, that's B-fib. All right, Rhythm, you know that. What's your first treatment? What's your first treatment, or are you going to treat this patient?
Just impressions.
Okay. What does
First responder.
studies show, and actually is being advocated for medics, EMTs in the pre-hospital setting? If you find someone in that previous rhythm, they're gonna be in that previous rhythm forever and ever.
Stay with
So they could truly probably shouldn't do anything. However, the family's gonna dictate, okay? The nursing home, if you're not ever gonna go wrong by treating that patient. Even if they had a DNR that you didn't know about, and the family's gonna sue you, it's better to be sued for battery than abandonment, okay? You're not gonna lose in court for starting CPR and working somebody assisted. On an abandonment, which is be what you were doing, so you didn't do anything and you left. They left from court, you're gonna lose every time.
So
Well,
if you do start CPR and then they bring in the DNR, you just stop?
you can stop,
Okay.
obviously.
Okay.
Because that's their wish.
Right, okay.
Now, here's the crazy thing about DNR. Say, Cam and I get together, the kids say, I don't want anything done. I don't want CPR, I don't want intubated, I don't want this, that, or the other. Right? Any one of them can override that. Yes, they can. That argument.
Can you write your DNR? Please do like nobody.
You can do like Steve Day. I know Steve Day is a blast of the past, probably the greatest, one of the greatest EMS instructors in Arkansas. He was and a pretty good medic. He told me we knew each other for 30-something years. He was gonna get big DNR tattooed on his chest. I don't think he ever did. But he said he didn't want anything done when he went to cardiac arrest. But anyway, the treatment here, is it a lot different than the treatment for someone that was in PEA?
No.
You can give a lot of oxygen, a lot of CPR, a lot of epinephrine. Used to, they advocated giving atropine. It's not gonna do any good. If you just want to for giggles, I guess that's your business, as long as you put it in your report. No, don't do that. So, do you transport the patient? Well, if you're working, you do, don't you? What's the outcome gonna be? It's gonna be DRT.
So
Yeah, right there.
I know our protocols are gonna be changing to Baxter's. What is Baxter's protocol
You have to
on
ask her, I don't know.
treating in place? I know, because it used to be you perform CPR for like, what is it, 15 minutes, 20 minutes?
I believe it is 20 minutes.
Okay, well, I'm seeing that there's no change in call medical direction.
And
To me-
it sounds like it's pretty much the same. The biggest thing is that if you have a rhythm change,
Mhm.
you need to transport.
Okay. You know,
Okay.
the statistics show this to be
I don't
true.
think we have a protocol.
I don't think for any that says if a rhythm changes, you
Yeah.
do know. But the statistics show, and I'm not gonna quote a study because I don't know which study. It's been known for a long time. If you don't resuscitate this patient in a pre-hospital setting, they're not getting resuscitated in the ED. I'm talking about the ones in cardiac arrest. They're not. Not to be, they're going to be discharged. You may actually get a pulse back on someone in a systole, but that's your epinephrine one. But they're not going to be discharged from the hospital. But that doesn't say don't treat them. Obviously, we're going to treat your patient unless they have that DNR living will, etc.
Well, technically that's treatment. Technically that's treatment.
DNR?
Yeah.
You don't do nothing? It's
Yeah.
treatment? Treatment is actually, to me, is an active skill. You're doing something active. Doing nothing is not active.
Well, I mean, you're following
I'm being a
policy
jerk.
though. I mean, you're following your protocol, which is,
You're doing the right thing, yes.
Yeah.
I understand what you're saying. I'm just being sometimes a little bit of a jerk. Okay. What happened here?
You got stopped.
You got shot. And that's not like a 110, is it? No. And then he fell.
There's a
But you
trauma.
don't know what actually caused him to be in this particular rhythm.
Did he
Probably
fall?
the
Did he
shock.
get shocked or did he?
Well, he got shot first, okay?
And then-
But who knows? First thing I want to know is the scene safe. I mean, did the power line come to the ground when he fell, etc. But they did start bystander CPR immediately. Good thing. What's your rhythm? VFib. That's a very coarse VFib, isn't it?
Mhm.
Is there a possibility of resuscitating this
Yes,
patient?
yes. The
Yes.
quicker you shock, the better out.
Yes, and they're doing CPR, but what you want to do is rapid defibrillation. And we don't stair step them like you used to in the past. You shock them at what? Your biphasic at 200.
Mhm.
Do you know that some of your biphasic monitors, they'll only shock at 200? You may be able to physically turn it up to 360, but some don't perform that. Some do.
Mhm.
And the reason they did that initially was this old folks that started out 100 years ago that you shocked them at 2, 3, and 360. So that was still in your head. Well, even if you turned it up to 360 on the old Zolls, probably even some of the life packs, it would only shock at 200. That's really why they did it. Now, don't be misled. I think your 15s, you can go up to
You were
360.
supposed to do 200, 300, 360. You are. Like that.
You used to. Now they say that you shock mid, unless it's changed.
No, it's still 2, 3, 360. Yeah.
No, I mean, you don't stair stack them though. Am I correct in that?
the new
Is
ACLS.
you don't stair stack.
That's what I was under.
You shock them at 200.
Every time.
It depends on your monitor. I don't care, but I think most of the monitors, the biphasic is at 200.
No, they stack. They go. Once you shock and once you recharge, it'll go to the next step for you.
Okay.
So it goes
That's
200.
incorrect.
Yeah, it goes 200.
But
and
you
then
don't do
recharge
what I'm
again.
saying, you don't shock them 3 times in a row.
Oh,
You
no, do
shock
another
and then
round.
med CPR
Yeah.
for 2 minutes.
Okay.
That's what I mean, a stair
Okay.
stack.
Okay. We're all the same page.
Okay, no, and I'm not doubting it at all,
No, okay. No, I was missing.
but I was thinking that was something that changed in 2020 or maybe
Okay.
2016. I can't remember when.
I remember you talking about, yeah, you shock them.
You shock 3
And
times
then you
before
shock
you
them
ever
again,
do
and then you
anything.
shock them again.
Yes.
Yes, okay. That's, gotcha.
So anyway, you're gonna obviously
It was an
defibrillate.
idioventricular rhythm.
Huh? What are you talking about? Okay. What are you mad for this epinephrine, obviously? We're gonna try to go more rapidly. I'm taking too much time. I've got another Zoom.
Oxygen.
Okay, IV cardiac monitor, we're ventilating, obviously, doing CPR.
Lidocaine or any other.
Okay. Which works better?
Lidocaine, there's debate.
Very big debate. You know why they, why like lidocaine out years and years ago?
They took lidocaine out?
Long time ago, they did.
One time there.
Because it was still, your medical director could still say, I want you to use lidocaine. But AHA took it out because it was not scientific based. They had never done a study on lidocaine working for VFib or VTAC, pulses VTAC. But there has been studies since, and actually the survivability is a little bit better for lidocaine than it is any other drug. No, don't carry it. That's because Bozeman, old school like me.
I like a lot of games.
So anyway, one of those two. Epi every 3 to 5. Hopefully the rhythm changes.
Well, he just came right back to us.
And
Hey.
intubate them. You're gonna carry them to the hospital.
It's hard to stop mid-sentence and then started talking again.
What's his machine?
That's just to keep your arms up, sir.
Yeah. Lie to the patient.
We hooked him up to our Lucas. And then he came right back and he's like, what's this machine? We're like,
When he kept asking me to hold his hands, he said, my hands keep falling, my hands keep falling. So that was just, I said, well,
Hey,
we're just putting your hands where they don't fall anymore. But he would go out and like, it was a V-fit, wasn't it? And he would be talking, and then when he would go out, and then when the shocking would come back, just start.
Yeah.
it was crazy.
wow.
We shocked him 5 times in round, and then they shocked him, what was it, another 6 times?
Oh man, it was so funny when we walked in the air. We don't need to go to number 9. Yes, you do. Just wait.
And they come back down, or from down upstairs,
We're like, oh, he's back in me.
and they're all red faced and tired, and so we were doing CPR in the elevator. Don't do it.
Yeah.
Yeah.
Here's the thing, freaking listen.
Yeah, seriously.
Good.
Just because he's walking, talking now.
Yeah, most people are before they have the big one.
They asked on the radio, because I said we were shocking or defibrillated. They said, did you mean defecated? No, but defibrillated.
Yeah, I defecated on my face.
6 times.
You know what? Never mind.
Yeah. Anyways.
All right, what's that? No pulse. Pardon? Well, it's a problem, and it's telling you what the rhythm is.
It's VTAC.
It's VTAC, but it's pulseless. So you're gonna treat that cow
Very
the
careful.
same way you did the previous rhythm. The same way.
You guys got them.
I'm gonna stop that femur bleeding, because I mean, there's not gonna be much.
Well, that's a problem too. That's why you have first responders, basically, and page. You doing the paragod stuff and let them take care of the, no. Yeah, I mean, here's the thing.
I
Guys,
don't think that's paragon. That's utilizing your tools.
you know
because
nothing about
I'm
sarcasm.
just an
I'm not a
ENT.
You remind me of Monty Haley. Does anybody know Monty Haley?
Yes.
No.
Don't call me that.
Hey, he's very intelligent.
He is very intelligent. Just because I'm not very good at social cues, Sheldon.
Okay. You're absolutely right. Maybe this patient is bled out.
Yeah, volume.
So don't forget about that, obviously. But you're going to do your medic skills also. Okay. Here's the thing though, if a patient is volume depleted, you're not getting them back. But here's the problem. They don't advocate giving massive amounts of fluids. To be honest with you, you should never give more than a liter.
Permissive
$500.
hypertension.
Exactly. This patient is not, they're hypovolemic probably, and they have a 0 or 0 blood pressure. But you could give them a fluid challenge.
Yeah, TXA.
Give them TX.
And
Here's the
stuff.
thing though, if they're not perfused,
Yeah.
well, if you're doing great CPR, might help.
We're doing great CPR.
Doing great CPR, it might. And they have a head trauma, so this patient is head barred, right? But the treatment, other than it is traumatic, because it was MDC injection, you have to think about, we always think about patients
We've
at
seen
home.
it firsthand.
They do, they can. These patients can. Especially if they're young, they can. So it's not impossible to resuscitate this patient. But here's the thing, you would not want to stay and play on the scene. No. You're en route because it is trauma. Where would you take this patient to?
A bird.
Well, you hopefully, but here's the thing,
They're not gonna
if
transport.
you're doing
Oh, wait,
CPR,
yeah.
they're not gonna.
Oh, we already brought it back. That's what we-
Okay.
Okay.
You brought them
I got
back.
ahead.
Brought them back. Great job, brought them back from flying out, but what if not?
Your Fulton, the most,
You need to go to the closest appropriate facility, and that might be Fulton initially,
We
okay?
got trauma
Because
comes
we're
on
in
the same
cardiac
floor.
arrest.
Yeah.
Are you gonna wanna take one that, this happened at the ball field out here? Are you gonna bypass this facility to take them to Baxter?
No,
That's foolish.
I'm not going
That
to
is
that.
foolish. Let them here because they can get some blood. They only carry, I think, 2 units here, I believe.
it's a little bit more
They
than
used to only carry 2, maybe it's whole blood. No, they don't carry whole blood. They have FFP
Mhm.
and they have, what's the other one?
Oh,
Go ask.
Yeah,
But they don't carry much,
right, I knew it wasn't very much.
but they can give them some blood,
Enough to stabilize.
some FFP or
Mhm.
whatever they carry. And that would help. And then give them some fluid, okay? And your TXA would be great. We said that you did
Only because,
TXA.
there was injections, so we can't, they could have internal bleeding anyway,
Yeah.
so that would help out a
Yeah,
lot.
definitely. You don't know. But let's say that you brought them
What?
here and they get resuscitated, but they're not gonna stay here.
Acres,
Yes,
like,
ACERS. Or is that ACERS? Acres.
Are you playing during class?
No,
you're talking like Ozark Acres?
yeah, ACERS.
I think so.
Yeah.
We have 4 for emergency use, but they carry 6 total.
That's FFP?
Yes.
Yeah, I thought it was four.
Okay, they have to thaw it.
Yes.
obviously.
Yeah.
But you would be since you couldn't fly that patient, I would stop here. I'm not bypassing this facility. All right,
Get ready, we need it.
this, let's just go ahead and say what this is. It's a PEA
Yeah.
because they have no pulse and no respiration. Okay, we're not gonna go through the entire treatment. This patient was assaulted with a baseball bat. Okay, very good. What else might be wrong? They may have a pneumothorax. They may have cardiac tamponade. It may be a head injury. Don't know. You
Lacerated spleen.
exactly, you
liver.
assess your patient. don't you? So anyway, obviously CPR is in progress. And you're gonna treat this patient, you may give them a fluid bolus. Treat your patient, not the monitor, is what I'm getting at. What is really wrong with this patient? Yeah, they're in cardiac arrest, but why? That's your H and T. This is taking a little longer than I anticipated. What's that rhythm? That is a third degree. That's a classic. It's not a classic, it's a complete heart block. That is a classical looking third degree. What is the pacemaker site for this particular rhythm here? Pardon me?
Isn't that saying that?
No, absolutely not. Those are SA nodal beads.
No. That's
What the QRS, what is the pacemaker site? Easy way to tell them this. Generally speaking, nothing is absolute. Okay, it's wide. Purkinje fiber.
Purkinje fibers.
Okay.
What's after that?
If it's narrow,
Hold on.
I don't know.
Hello.
Okay, generally, that is the treat. It doesn't really matter that much as far as your treatment's concerned. If
Okay, we'll be there in a few minutes.
if this was a narrow complex,
Okay.
if it was a narrow complex QRS, that would mean it's not coming from the Purkinje fibers. It's probably coming from the AV junction.
AV junction, that's it.
But here's the thing, it's a third degree block, and most of them you're gonna have wide QRS complexes. And sometimes you have a retrograde conduction. We're not even gonna go into that, it's a little more complex. But this patient's in a third degree block. How would you want to treat him? Oh, to an IV cardiac monitor, obviously.
Can you pay for?
This patient, this is my opinion, is doing a lot of research and having some critical thinking skills. But this patient, if it were mine, they're symptomatic. If they're asymptomatic, let's don't mess with them.
Right. They're symptomatic.
They're symptomatic, I'm patient. Do you want to know why?
Because atropine doesn't work.
Let me tell you what atropine does. It increases the firing of the SA node. So now you're going to have many more P waves, and that tends or has the ability to slow that R far down. You may go from a rate of, that's about 38 or so to 15.
Mhm.
It's possible. Now, if you go by CLS, if they, sure, you can give activity.
It says not to give it after.
I wouldn't
That's
give it.
what-
I
yeah,
would-
it says
I
it's
would not give it.
Yeah, it's contradicted after a second degree type 2 block.
I would not give it.
Yep.
I'm just saying, there is literature out there that says you can. And if I'm not mistaken, it still says that in the HA algorithm. But you're absolutely right.
Yeah.
You don't want to slow that rate down anymore. And what's the problem with a rate like this is your cardiac output is decreased so much generally. And I had a little old lady back in the day. This looked a lot like the rhythm she had. Hers is in the high 20s, low 30s. GCS at 15.
Normal.
Alert and oriented, talking to me like no problem. That's kind of an embarrassment, isn't it? She was fine. Well, she had to get a pacemaker, but I didn't have to do anything to her. O2 IV cardiac monitor. You don't treat that if it's stable. And here's the thing: the less, and this is contradictory. Some people say you're wrong, blah blah. That's fine. I've been wrong a lot. Don't do something your patient does not need as far as medication wise. Once you give that medication, you cannot pull it back. So the least invasive that you can do, the better, unless it's indicated. Okay, let's move right along. This is like, there's going to be a lot of sad singing and slow walk. You know what that means? This is an angle rhythm. People can say it's an IVR. Okay. It's a dying heart. Now, the patient does have a heart rate. So they're not dead right now. So what are you going to do for this patient? O2.
Get your finger blood,
Yes.
IV fluids.
IV fluids. Can you give them some atropine?
Mhm.
Is it going to hurt them any? Probably not. This patient is not going to do well, obviously. They probably had a massive MI. There again, you never say there's no possibility of this patient be discharged from the hospital. We don't know. Who only knows? Kind of like some of those rhythms out there. The GOK was what we used to call rhythm back then. God only knows what that rhythm is. I could tell though. Excuse my language. So, or they were having FLB. Whatever. I want you to learn something. Find a little bit. And here's the thing: in your career, if you stay in it long enough, you'll have rhythms you have no idea.
Yeah.
You'll have absolutely no idea what it is. Do you know what's important? Your patient is perfusing, they're alert, and have good blood pressure.
That's all that matters.
That's all that matters. Let that cardiologist figure it out. So this patient will not probably do well. Okay, let's look at this. Now in the 2024, 25, 26, back to 2006, you wouldn't have misdiagnosed this. But back in the old days on your Life Pack 5, which is like,
Oh, Lord,
what's a
yes.
Life Pack 5? That was something I used 36 years ago, I guess. But if you look at this, this is a male patient with plenty of nausea, vomiting, weakness, GCS of 15, blood pressure 150 over 77, pulse rate 86, respiratory 20. But your cardiac monitor is showing what?
He did.
He's showing what's it. Is this person in a situation?
Sir.
That ain't happening. You know, in the old days, now in this day and age, your monitor will say lead off.
Oh,
Back in the old days, it did not say lead off.
that's one thing you had to fight.
It didn't.
Fight that.
Exactly. But what I'm getting at is, well, I threw this up here. Don't treat your monitor. You always treat, no, you don't treat your pulse ox. You don't treat your glucometer. You don't treat your monitor. What are those? They're tools.
To diagnose.
Exactly.
Would you diagnose them with it?
So when are we gonna do this? Hey, I'm gonna hook that lead back up, and guess what? They're in a normal sinus rhythm. And they got a little bit of nausea. They're a little weak. IV, give them a challenge and give them some more. The great man that was been out a few years.
So
Zofran. Did you give him vinegar?
if you want.
What's the problem with giving someone vinegar? Yes, you got to dilute it. You need to dilute it.
Oh,
You
I
have
found that out the other day.
1 ml. Get your flush. Pour it out 1 ml. Mix it. Then you can give it. You give it slow. Can you give it IM? Sure. Yes. Better to give it IM, personally. Let me tell you something. Vinegar works on me a lot better than Zofran. It lasts a lot longer, makes me want to sleep. But Zofran is a wonder drug. They actually used it for what? Why did they so-called invent it?
For cancer
For
patients?
cancer patients. It used to be very expensive. Not that expensive anymore. So this patient, we laid hands on them and we cured them.
Like we just did.
And we high five. We did a great job. I think that was in here when I was talking about the resuscitating the guy and Stacy right now high fiving him. Little did we know we were idiots. This is a problem.
It's for SARS, isn't it?
Yes, originally it was not. But originally there was a sinus that looked like it started having PVCs, and then it went in. I don't see it really an ROT phenomenon, but it went into a rhythm that was recognizable to that, and that's Torsades. And there's no point in us going through all of what med did we have that we can treat it by itself there. Have you ever seen it? I've only seen it twice.
Yeah, I've seen it 3 times now.
Awesome. I've seen it twice. That's it. There's a reason I put this one up there.
Weakness, defensive negative for stroke, heart rate restoration, SpO2.
What's the key, right? There's 2 keys in this one. Then you look at this and you're seeing a normal sinus rhythm. Tasia, you're gonna have to scoot back or I'm gonna have to step on. There's 2 things I want you to look at here.
Weakness. Oh, the age and the weakness.
In the weakness.
That's every.
Think cardiac. Okay. If I'd thrown in there a syncopal episode and now that we definitely think cardiac or blood glucose. Okay.
Or they're just weak.
Or just weak. Exactly. But on this particular patient, you need a 12 lead on this patient.
Because that.
And here's the thing. This isn't being disrespectful. We just call them LOL, the low leg. That they can be having an MI and their signs and symptoms are not textbook. They may be even asym other than they're weak, they're dizzy, or had a syncopal episode. So do your 12 lead EKG on that patient. And it comes out fine. There was no ST elevation depression.
Right.
So mainly she's just weak. Okay. She may need some fluid.
They're gonna come get their,
Wow.
yeah. Okay.
Wow.
The South Fork section.
You're
coming
kidding
in.
me.
I know.
Nice, glad.
So we don't have to do it.
We all went into this 12 lead.
Yeah.
We're all
Okay.
shocked.
I think this is the last one.
Can you zoom in
Can you zoom in on that by chance?
You know how to do that.
I don't know where my glass. Oh,
This is the mouse.
yes, I know how. Just give me a minute.
Whoa.
Is that too big?
Oh.
Fuck. What? I mean, this just slaps me.
That's an inferior.
Where's my? No, because that's crazy. I am a little.
We're all crazy.
Okay, man, that just like.
An inferior am I?
Quit hitting that screen.
I didn't pay for it.
It's
How about
not
this? This is
smart.
depression.
That's
isn't
your
it?
depression and 2. You wanted me to.
So this is a problem.
Mhm.
First thing I'm gonna do after you get my O2 IV cardiac mars, I'm gonna throw a little nitro down. See how that.
Sounds perfect.
You wouldn't do that?
Not because it's an inferior, but because it's blood pressure.
What if it's me?
Oh, I would do it just
You
for the hell of it, yeah. Like,
No, of course you would. We don't want. Why do you not want to give nitro? There's a reason.
You,
because you decrease your preload.
Outstanding. That's what is preload. Now you tell me what the amount of blood's returned to the heart from the system.
Yes.
The what? Inferior, superior.
Very good.
What's afterload?
So after the load of the blood.
Okay, let me simplistically, it's basically the amount of blood that's ejected from the left ventricle.
Yeah.
It's a lot, it's the same age that stroke volume.
Yeah.
Okay. So this patient's a problem. Are we gonna bring them to Fulton County Hospital?
No.
You're an idiot if you did. Excuse me for saying that. Where does that patient need to go? Quickest PCI. And I had trouble pronouncing that stuff the other day. Michael had to look at it. Percutaneous.
We did
coronary
have to look it up because
intervention.
I didn't know what that was.
I couldn't pronounce, some words I have trouble pronouncing. We're gonna do what? O2 IV cardiac monitor. There may give them a fluid bolus. I mean, I'm not saying you do. It depends on the blood pressure.
It was low, it was 80 over.
Was it very low? Then
Yeah,
they
we need that.
They give them, fluid challenge.
And once the blood pressure come up, I give some morphine.
If your blood pressure does come up, yes. But now here's the thing about morphine. I think I talked about this the other day. It can also decrease your preload.
Okay.
Not as good as
But you're also
nitro.
already, I mean, that'd be a better, can also better than using a nitro on that.
Oh, yeah, yeah, you're not using nitro.
Right. What about what?
What about the side effects of fentanyl versus morphine on her?
It's not, here's the thing, fentanyl's not gonna hurt this patient. Why, okay, let me back up a little bit. This patient's in part,
Yes.
right?
Mhm.
Okay, they're excited. I would be,
Oh,
okay. Myocardial O2 demand is increasing. That's a problem. Because it can create enlarged brain infarct. They need to be on a little bit of oxygen. I don't care what that monitor
They
says.
don't help.
Little bit. I'm not saying 15 liters.
15 liters on our breeder.
But why do you give nitro, or not nitro, morphine to these patients that are having an MI? Well, pain increases the heart rate, increases myocardial O2 demand
It's
also.
It's a
So when you give that, to a certain degree it is,
Right,
you're absolutely right. But one reason you're giving it is to take care of that anxiety and the pain, and it doesn't cause a larger infarct than what's already there.
Good.
That's a rationale behind giving morphine. So this right here stands out. No one would miss this. No competent medic, no competent medic would miss it.
If it's not right up there, some people will catch it.
Well, I'm sorry, but yeah. What do you say?
Read the 12 lead, not the.
And treat your patient, right?
The title or label of it.
Yeah, was it that
Don't
reads
read
it?
it,
Oh.
The interpretation?
No.
The
Let
interpretation.
me tell you something about the interpretation on the cardiac monitor. It's only right about 85% of the time.
There's
And that's the
usually-
best case scenario.
And there's people that actually just read that.
Oh,
Don't.
What I have to do when they come off is I'll just grab it and then I put my hand over that part, because I don't want my mind
Going to it.
going,
Exactly.
okay, that's what this is.
But
There's
it
also
is
nothing
right
wrong.
a lot.
Yeah.
But
There's
it's
also
wrong
nothing wrong
some too.
to double check and be like, okay, well, this one I
Always.
think
A
is
lot of
Double
times
check.
if I can't
Always.
decide if it's a February flutter, and it'll be like, it's in flutter, and then I go back and I like count, why is it a flutter?
Yeah.
And I like that.
One thing about, to me, A flutter's easier, really easy to, I don't want to say diagnose, identify.
Mhm.
And I think AFib is also. That's just me. It's like the blocks. I have no problems with blocks. I think it's nurses, love nurses, married a bunch of them. I like that.
Stop.
But,
Great.
shut up.
You only hit one with the newspaper though, right?
Yeah, right. It's a long story. I'm not a business fan. Yeah, you just threw me off of Russ.
Nurses are great.
Oh, I find when I do basic arrhythmia class, those are the rhythms that give them the most trouble.
Yes.
And there's an easy way that I explain it. I'm not gonna go through it. You guys all know how to determine rhythm. But really, I think helps them a lot. Is just the way I distinguish the different blocks.
Yeah.
Anyway, they said it's pretty good. I've had some say, I don't know what you're talking about. I was a medic instructor once, you got to evaluate every year. And you got to see your evaluation, you know who wrote it. One of the questions was, does your instructor know his material or what he's talking about. Yes, but I have no damn idea what he's talking about. Well, I don't think that's probably a very good evaluation. Anyway, I'm done. I hope you learned something, probably not.
Yes.
But I've got to go do some stuff. All I got is better check. I don't know if it's 11 or 12. I think it's 12.
You told me.
I think it's 12 to 1.
Well, good golly, you still got an hour.
Well, I'm finished. You went through half of my stuff.
I know I missed the Ross. but-
You said 12 to 1.
Okay, but I'm finished.
Okay, you got an hour.
We got the end of it.
No.
I know that.
I don't think, Tasia, I don't think so.
I'll find it.
Well-
Okay. Here.
We was here. Is that it?
Sure. I went
Okay.
through it a lot faster than I
Oh,
normally
got a
would.
question, Tim.
Uh,
On this one, since they didn't pay this out in 2102 requested us, do I need to write it?
No.
Didn't think so. Okay.
You were not dispatched by dispatchery.
No, just Greenville asked us and then.
Yeah.
we
All right, we're gonna
immediately-
take another 10-minute break. When we come back, we are gonna have Mike do
Culture of safety.
culture of safety. So y'all stick around.